think at the current stage, the limit is that you can only use a certain amount of optical power safely in the eye without risk of damaging the retina. And that means the amount of light you collect is limited, and we actually reach quantum noise limit.
So the paper came out in 1991, and then how long did it take for the ophthalmologist to start using it? What was the time frame between it was like conceived, the OCT, and then it became like the standard of the retina scans?
And FDA approved.
That's right. Yeah, FDA was definitely, I guess, part of that.
The FDA wasn't that bad back then. The first system for eye imaging went on sale in 1996, and that's only 5 years after our initial paper in the journal Science. I thought that was very fast.
That's extremely fast.
Yeah.
Yes.
Going from initial laboratory demonstration to an FDA approved instrument. And then in the year 2000, it received a CPT code. That means there's a special code that's recommended by the American Medical Association, and that would get reimbursement from Medicare and other insurance. That's also very fast. These days, you would expect double the delay, but those were not the main impediments. I think initially, clinical acceptance took some time. The first two models, OCT1 and OCT2, marketed by Zeiss, were sold only to major academic centers. And some retina specialists especially really saw the potential and were big fans because they recognized you could see new things, details that they could not see directly on OCT. Whereas I think most ophthalmologists actually thought it's like a toy that produced grainy images that looked very strange. But there were a lot of clinical publications on applications in various eye diseases, and that started to catch on in early 2000. The main application that became really popular was just simply measuring retinal thickness and edema in age-related macular degeneration that was starting to be treated with injections in the eye, with antivascular endothelial growth factor treatment that were effective in taking away that edema and loss of vision. So now you can measure something, prescribe a treatment, and then see actual clinical benefit. And this was a disease that was the number one cause of blindness. So it was a major breakthrough. So around early 2000s, OCT really, found a killer app.
Is that the antibody drug?
Antibody drug, yeah.
How does it work exactly? What's the mechanism?
VEGF is the molecule that was critical in the growth of abnormal blood vessels, and also it increased the leakage, fluid exudation from those vessels that cause swelling of the retina and loss of vision. So when you block the VEGF molecules with antibody fragments so that they don't reach the receptors, you actually cause involution of the neovascular membrane and also reduce exudation from those membranes. And then you restore a normal retinal anatomy and restore better vision.
Why was OCT needed there in order to diagnose it or to find the place in the eye that it was happening? Or
OCT allow you to see the change in retinal thickness, and you can see fluid pockets. So you can measure the edema, and you can also see the abnormal blood vessels, the neovascular membranes under the retina on OCT. So using OCT, you can identify patients who would benefit from these injections, and then you can assess whether the treatment is effective or not by measuring the thickness of the retina, most importantly in the central retina. And that became a treatment endpoint that's very accurate. Because some people would have improvement in vision, some people would not. Just measuring vision is not a very reliable way of really validating the activity of the drug. But measuring retinal thickness is a more reliable way to monitor the treatment.
So that AMD, before it was under the radar completely, people would just get blind and no one would knew what to do with it and how to treat it. And then with the OCT, that was the possibility to diagnose people with AMD.
With OCT, you can see these lesions at an earlier stage, and you can also see edema more reliably. Before, often you can see these lesions at a more advanced stage. For example, when they bleed and you have a big red spot on the retina, it's not hard to see it directly on slit lamp microscopy, but then it would be too late to intervene because often the vision loss would be irreversible. You can also see leakage on fluorescein angiography, and that's injecting a fluorescein dye intravenously and looking at the fluorescence, which was also a significant imaging innovation. But that's more invasive, and you don't see the neovascular membrane as reliably as OCT can.
Maybe going back to one more technical point, you were mentioning the Moore's law of OCT, where the speed doubles is every 2.5 years. What is the main limitation to speed, and what can be done or is done to increase the speed?
I think initially the limitation to speed was the need to scan the reference beam length mechanically by moving a mirror back and forth. So that's a mechanical limitation. Later on, with Fourier domain OCT, where you use either a spectrometer or a tunable laser and a fixed mirror in the reference arm, there's no longer a mechanical limit. I think the limit then becomes the speed of either tuning the laser or the speed of the line camera used in spectral domain OCT. So the limit becomes the speed of laser tuning in swept source OCT and the speed of the line camera, how many frames per second it can capture. And those have been increasing steadily. I think at the current stage, what's the limit is that you can only use a certain amount of optical power safely in the eye without risk of damaging the retina. And that means the amount of light you collect is limited. And we actually reach quantum noise limit in that even if you increase the frame rate of the camera, you can acquire an image faster, but then the signal to noise ratio would be unacceptably low. So that limits the acquisition rate to several 100,000 axial scans per second currently. I think the way around it are either going to be a parallel acquisition or shining multiple beams into the eye at the same time, each one of which have safe enough low power.
Or if you want to be extra fancy, you can use squeezed light to go sub-short noise.
No, that's difficult and limited yield. Or you would need to increase the optical power, but guarantee that the laser beam never stops moving. It never dwells on a single point to heat up the retina excessively. So the amount of optical power you can shine into the eye is the limitation right now.
What is that power typically? Microwatts or what is it? And I guess it's over area, but in what range is considered safe at the wavelengths you use?
At 800 nanometer, it's about 0.7 milliwatt. And at 1050 nanometer, which is another water transparency window, you can go up to, I think, something like 5 milliwatts. It's probably feasible.
Regarding the cameras side, so you said it's like 1050. Are you still using the silicon CMOS ones? And my other question is on the sensitivity side. Can you improve it by using like more sensitive cameras, something like EMCCDs? I know it may require like they're more expensive and require like special cooling, but would it push further the frontiers of the OCT in terms of the speed of the scan?
More sensitive detectors certainly helps, but I think the detectors are already quite sensitive in terms of the quantum efficiency. And so there's not a lot of headroom for gain by improving that.
And you still use, is this the just a traditional silicon? Because I feel like it's at the boundary of the band gap for the silicon,
Yeah.
the wavelength you're using, or you have to use those like indium gallium arsenide, the like 3.5 type of detectors, which I guess also may increase the price.
Yeah, at the
for-
longer wavelength, generally the 3-5 types of detectors. And that's why tunable laser or swept source OCT is generally used in that implementation. Whereas at 800 nanometer, generally one would use a spectrometer, spectral domain OCT, and CMOS cameras, line cameras are generally used.
Are there any water transparent windows at even lower wavelengths? Because I suppose you could get better resolution if you could work at a lower wavelength, or are those
Shorter
more
wavelength,
damaging?
sure. In our laboratory, we're using visible wavelength. I think for retinal imaging, it's really more experimental because it's too bright to easily use in the clinic.
Yeah, because of the reflex of wanting to
Yeah,
blink
it
your
will
eyes. Yeah.
constrict the pupil, and even if you pharmacologically dilate the pupil, the patient will find it difficult to tolerate. And
Right.
the benefit there is that at the in the yellow-green region, you can use differential absorption of oxy and deoxyhemoglobin to measure oximetry in the retina, which is very interesting for research. But I doubt that that would be used widely. We also have visible wavelength OCT to capture finer details. And we also have a project for corneal OCT. I think it might be easier to tolerate if you image the cornea. So by the time it gets into the eye, it would be extremely wide field illumination, and it would
by
be
the way,
easier to tolerate.
I just went to an ophthalmologist recently, and then when they do the cornea scan, is it also done by the OCT scan or?
Yes, yeah, you can have corneal OCT.
Interesting. Yeah, that was really cool to see the topology, and they would explain what
Yeah.
what the
Yeah,
abnormal.
so the standard OCT system can be used to scan both a retina and a cornea, sometime by internal adjustment, sometime by adding a lens to change the focal plane. But those generally use infrared light, and the transverse resolution is generally in the order of 15 to 20 micrometers. You can have stronger focusing to look at cell resolution. That's called OCT microscopy. And with visible wavelength, you can see smaller features, even bacteria, which is one frontier that we like to work on. But generally, infrared is more clinically useful.